Very good afternoon, everybody, and a very warm welcome to our NITRD Central TB Division and National Task Force Collaborative Difficult to Treat TB Clinic. I'm Dr. Neeta Singla, Nodal Officer for ECHO sessions at NITRD. We run 8 different ECHO programs from NITRD. On my right is Dr. Rupak Singla, who is head of the department TB and chest at our institute. And on my left is Dr. Amitesh, who is a chest physician in our institute. I'm joined by my support staff of ECHO India team, Mr. Gaurav, Mr. Prateek, and Mr. Rahul. We have been running the TB ECHO program for more than 4 years now. And today is a very special day for us as we complete the first successful year of difficult to treat TB clinic. On this special occasion, we have a very important guest with us, Dr. Soumya Swaminathan, who is the Chief Scientist, WHO. We are honored to have her with us. She has taken the academic and research potentials of India to new heights. A very warm welcome to DDG TB, Dr. Mandal, National Task Force Chair, Dr. Ashok Bharadwaj, Senior Faculty, Dr. Behera, Dr. Rajendra Prasad, Director of NTI Institute, Director of NIRT Chennai, State TB Officers, Directors of STDC, Faculty of Medical Colleges, Faculty from National Task Force, Zonal Task Force, and State Task Force, District TB Officers, and all the participants. I also extend my warm welcome to Dr. Sanjeev Arora, who's the global founder of ECHO Model, Dr. Bruce from UNM, Dr. Kumud Rai, and Dr. Sunil Anand from ECHO India, along with their team. A very warm welcome to you all. And now I request our director, Dr. R.K. Diwan, to give his introductory remarks. Dr. Diwan, over to you.
I'm unmuting myself. Good afternoon, everybody.
So you're muted.
I think, am I audible now? Am I audible now? I have unmuted myself from my side.
We can hear you, Dr.
Diwan. You are muted, please.
Yes.
We are able to hear you.
We can hear you. Thank you. So, good afternoon, everybody. As the Director of National Institute of TB and Respiratory Diseases, it's my, I think.
Now we can hear you, sir.
You can hear. Okay. It's a warm privilege for me to be welcoming all these guests, especially our chief guest, Dr. Soumya Swaminathan, for whose wise words we are all of us have gathered here. Response of TB control program in the days of COVID era. As all of us know, that the worldwide tragedy in the last 2 years has severely affected TB control programs. In my own National Institute of TB and Respiratory Diseases, though I can say roughly speaking that we run an OPD of 800 to 1,000 cases per day. And as soon as this epidemic hit us, the OPD got reduced to roughly 150 to 200 for most of the months of 2020, which has limped back to normalcy now. We run a very robust thoracic surgical program also, which does 700 to 800 cases per year, which also reduced to around 300 to 350 last year, and have again been coming back to normal. In addition, all of us know that at the larger level, the reporting of tuberculosis cases has reduced by 25%. And all of us know that Dr. Soumya Swaminathan is a distinguished career of being the Director of NIRT, Director General ICMR, UK Director General WHO, and as of now, the Chief Scientist. She has also been leading the worldwide scientific efforts to deal with this pandemic. So it will be very interesting to hear her views of how the pandemic has spanned out and how it has affected our TB control program, both the issues being close to all the respiratory physicians. And all of us have dealt with this unprecedented challenge in the last 2 years and are continuing to deal with it and are yet to understand its implications, short term, medium term, and long term, and how it will affect our practice, how it is going to change it, and how are we going to come successful out of it, how our world view about dealing with these situations changes. I know many people from CTD and many luminaries and galaxies have joined who have been in the forefront of the fight of TB elimination by 2025, a goal which all of us are concerned whether it is still reachable or not. So these are the main areas. As my colleague Dr. Neeta and Dr. Rupak have already told me that this difficult to treat TB clinic, it completes its 1 year. It's its anniversary. So we are very honored to have you, Madam Dr. Soumya, here on this occasion. to commemorate this occasion because we are really completing 1 year. On normal other days, we are across the country, we present our difficult to treat TB cases. Those cases are discussed threadbare by experts and then even discussions from all the people. And normally the attendance is between 800 to 1000. Even now, as of this moment, 375 participants have joined, and I'm sure after some time it will reach 800 to 1000 easily. This gathering. So it's a very important gathering of people who are TB workers as well as people who are concerned about respiratory medicine, its implications. And on such an important occasion, we are really honored to have your presence, and we hope to get enriched by your views. Thank you so much, and thanks everybody else for joining. Thank you. Over to Neeta.
Yeah. Thank you, Dr. Diwan sir. And now I request Dr. Rupak Singla sir to introduce our speaker.
A very good afternoon to everyone. You know, it's a very proud moment for me as this concept of difficult to treat TB clinic launched by our institute is completing its 1 year. And I'm sure it has benefited thousands of TB patients as well as helped in the capacity building of the physician across the country. And we can assure you that once more and more states start their own state level DTTC clinic as mandated by the Ministry of Health, we are there to provide you with all kind of support which you need. We are there to handhold you. So have faith in us, we'll do that. And I also thank Dr. Diwan, our director, DDGGP, Dr. Mandal, Dr. Bhartwaj, Dr. Malik from WHO India office, and the entire ECO team, including Dr. Sanjeev Arora, Dr. Kumudra, Dr. Anand, who have helped in carrying out this endeavor all these years. Having said that, it's my proud privilege to introduce Dr. Soumya Swaminathan, and I'm sure there is no doctor in India who does not know Dr. Soumya. She was appointed the Deputy Director General for Programs at WHO office in October 2017. And since March 19, she is the Chief Scientist in WHO, heading the division created to strengthen the organization's core scientific work and ensure the quality and consistency of its norms and standards. She is a pediatrician by training and is a globally recognized researcher on tuberculosis and HIV. She has more than 30 years of experience in clinical care and research and has worked throughout her career to translate the research into impactful programs. He has published more than 250 peer-reviewed publications and book chapters. Prior to joining WHO, Dr. Soumya was Secretary of the Department of Health Research and Director General of ICMR in India. From 2009 to 2011, she also served as coordinator of the UNICEF, UNDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases in Geneva. She has been a part of several WHO and global advisory bodies and committees, including the WHO Expert Panel to review global strategy and plan of action on public health, innovation and intellectual property, the strategic and technical advisory group of the Global TB Department at WHO, and was the co-chair of the Lancet Commission on TB. I personally know Dr. Soumya for several years, and I must say above all, I find her a very nice human being and is easily approachable, and she has shown keen interest in improving patient care and research in the field of tuberculosis in India. In the interest of time, I'll stop here and request Dr. Soumya to please enlighten us on the topic of the day, that is TB in COVID-19 times. Dr. Soumya, ma'am, please.
Thank you. Thank you very much, Dr. Diwan and Dr. Rupak Singla, Dr. Neeta Singla, first of all, for having invited me to be with all of you. And it's so wonderful to be with all my colleagues, ex-colleagues, friends, distinguished seniors, and of course, all the district TB officers and other TB, I should say, frontline workers and heroes who actually do all the work on the ground. So thanks for giving me this opportunity, and also thanks very much, Dr. Diwan and Dr. Singla, for your very kind introduction. So before I go into the presentation, I just want to say a couple of things. The first is that I'm delighted to see that Project ECHO India has really taken off. When I was a DG ICMR, Dr. Sanjeev Arora, Dr. Kumudra, Dr. Sunil Anand, the team came and met me. And that's when I first heard about this platform and recognized that it has huge potential for a country like India. And I'm really excited and happy to see that TB has been one of the problems for which this platform has been used. I know it's been used in many other disease conditions like mental health and hepatitis C, and many state governments now have MOUs with Project ECHO. But this is the power of digital platforms. And also very happy to hear that every week you have this discussions on the difficult to treat cases, and that so many people and so many patients are benefiting. So congratulations to everyone concerned who really, and you know, the success of ECHO, I must say that it depends really on the team that's running it. So all due credit to the team at NITRD for having put in the effort and sustaining the effort over so many years, and congratulations on the 4 years of successful running and then 1 year of the difficult to treat. And I hope that it continues to run, because we know how many issues arise, you know, when you're sitting in a remote district somewhere and you have a difficult to manage patient. This type of platform really helps you to discuss. And I saw during COVID also that the ECHO platform was used by several states actually at the peak of the second wave in India, when hospitals were overwhelmed, when many unusual presentations were being seen, and when there was a lot of confusion about which drugs work and which don't work, what the doses and the exact regimens are. We had experts, global experts, leading sessions with practitioners in remote areas in Chhattisgarh, in Gujarat, in Nepal, and in other states. And I believe that it really helped doctors get the latest information from the global experts. I would also like to hear from some of you today. I don't want this to be a one-sided lecture, because a lot of what I'm going to say, probably all of you know already. So what we need to do for progress, of course, is a two-way conversation. So at the end, I've requested Dr. Singla to request a few of you, especially DTOs, to share some of your challenges and where you think there are gaps and where WHO can perhaps address at the global and regional level, but also at the national level. The RNTCP and the CTD need to look at some of those issues. So if we can, Anita, you can help to share my slides, I will try to run through very quickly the initial part of the presentation, which is around the epidemiology of COVID and TB, the interaction between the two, some recent guidance from WHO. But at the end, I want to focus more on what do we do in the face of the pandemic in trying to deal with both infections and both are respiratory infections. If everyone can please mute their mics. Next slide, please. So that's just the outline of the talk, and I'd like to say a little bit at the end on the lessons that we've learned from COVID, how those could be useful for you. Next. I'm hearing some background noise, so if I can just request everyone to please mute. Next, please. Next. So this is the latest global picture of the epidemiology of COVID, and you can see this is starting from the beginning of 2020 till now. We have crossed 207 million known or confirmed cases and over 4.3 million deaths. And I emphasize that these are only the confirmed cases, and the true cases and the true deaths are several times higher. Within the previous 24 hours, we have something like 500,000 new cases every day. This is between 400,000 and 650,000 cases a day. And even deaths are still at a very high level, between 8,000 to 10,000 deaths per day occurring globally. The different colors on this graph show the different WHO regions, and we can see that both in the Americas means North and South America and Europe, they have from the beginning borne the brunt of the pandemic, and cases continue to rise there. The purple is the Southeast Asia region. India has come down, but then you have countries like Indonesia, Thailand, as well as smaller countries like Timor-Leste, which are facing outbreaks. And then below that, you have the Eastern Mediterranean region and the Western Pacific region, which in 2020 had very good control. Today, we see countries like Malaysia, Philippines, Japan having some outbreaks. And then on the right, you see the countries with the highest number of new cases, and the US actually should be right on top. They're, I think, over 130 1,000 new cases per day. Next. This graph is just, color-coded way of quickly looking at which are the regions showing very high new cases reported in the last week. The darker the color, the darker. So you can see again parts of Europe, Central Asia, and North and South America, as well as Sub-Saharan Africa. Next. And this is largely driven, by the Delta variant. There are still parts of the world where the Delta is still not really got a hold. This again is limited because of a genomic sequence limitation in many countries. But wherever Delta gets into the community, it really spreads very rapidly. We know that it's at least 2 to 4 times more infectious than the original Wuhan strain. And so increased transmissibility is one of the major factors, along with increased social mixing and a relaxation of the public health and social measures. And also in areas where vaccination rates are still low, that's where cases are also accompanied by high deaths. In countries like the UK, which have very high vaccination coverage, even though cases are high, the deaths are very low. So there's a disconnect between cases and deaths. Even in the US, the hospitalizations and deaths are largely among the unvaccinated, and that's mostly in the southern states where there's a very high level of vaccine hesitancy. Next slide, and the next. As far as TB is concerned, this is of course data from 2 years ago. We were actually, Southeast Asia was doing very well in terms of notification, approaching towards the modeled incidence, but the gap was narrowing actually between estimated and notified cases, but still the gap was 3 million. And now, next slide, during COVID, the gap has actually increased. Now, one of the recommendations which helped in narrowing the gap, of course, is the role of diagnostics, particularly molecular diagnostics. And WHO recommends molecular diagnostics, expert ultra, but also the TrueNat, MTB, and other moderate complexity automated NATs for detection of TB. And if you want to just detect TB without drug resistance, then we have LAMP and the lateral flow LAM assay. Next slide, please. However, the WHO policy is one thing, but then if you look at how many cases were actually bacteriologically confirmed, of the 7.5 million notified cases in 2019, you found only 57% were bacteriologically confirmed, and of that, only 58% were confirmed using a WHO recommended diagnostic test. So the issues why this is the case is obviously both access to these technologies. So again, the need for better, easier to use, more accessible and affordable rapid tests, and the cost is also, of course, an issue. So in the Southeast Asia region, again, we see 57% of pulmonary new and relapse cases were bacteriologically confirmed, and only 19% of extrapulmonary. Next slide. Now, when we look at drug-resistant TB, we know that the gaps are even higher. We expect about 1 million INH-resistant TB cases globally, and 465,000 MDR TB cases. And of them, less than half were notified in 2019, less than half the MDR. And INH-resistant TB is often missed, but it's much more common, of course, than rifampicin-resistant TB. Again, if you look at the graphs, the green lines on the right-hand side by WHO region, the Southeast Asia region over the last decade has been, increasing its detection of MDR TB, but still we are not reaching above 75%. And we see Africa and Latin America, it's actually quite low. Next. So again, the universal DST is the way to go. That's the only way to detect all INH and rifampicin-resistant cases. There are now updated WHO policies that are addressing the other drugs like INH and fluoroquinolones. And for some of the new and repurposed drugs like bedaquiline, delamine, and linezolid, unfortunately still limited to slower phenotypic methods. But again, I want to come back to the issue of whole genome sequencing or limited sequencing for rapid universal DST, because as you know, one thing COVID has done is brought the spotlight on the importance of genome sequencing, and the capacity for this is increasing rapidly in many countries. Next. Now, WHO has been working with a number of countries to have this repository or catalog of the mutations. And the reason it's important is that the correlation between genotypic and phenotypic resistance is not clear of the mutations. And if we want to move towards molecular detection of drug resistance, then we need to know what is the sensitivity and specificity of different mutations. So this compendium was released just a few months ago. And basically, if you look at just this drug rifampicin, you have a number of mutations in the rifampicin resistant region of the MTB, the RRDR. And then from that, we can look at the sensitivity and specificity of each mutation, being able to predict the resistance, phenotypic resistance. And of course, there's a discordance, but by using a combination of mutations or the most likely ones, we could actually arrive at a very rapid diagnosis of rifampicin resistance. And this needs to be done for all the drugs. Next. And one thing that I think India can certainly do with the amount of genomics capacity and big data capacity that we have, something that we had started a few years ago, is to have a national database of drug-resistant mutations, phenotypic and genotypic. NIRT had a database, but the best thing would be to pool all the institutional databases and have a national one, which is representative geographically of the whole country, so that one can then have recommendations which are very relevant for India. Now, in terms of what happened in 2020, WHO looked at a survey of 84 countries, which represent 84% of the global burden, and the countries shaded in blue are those that reported the data to WHO. The shortfall in TB notifications in 2020 compared to the previous year was 21%. So 1.4 million fewer people received TB care in 2020. And obviously this means that there could be 500,000 additional TB deaths potentially, because we don't know what happened to those people, whether they had a diagnosis, whether they got treatment outside the program, whether they never got reported. And the next slide shows some countries and what happened to the TB case notification. Next, please. Okay, we'll come to that in a minute. Emerging technologies, I think I'll come back to this perhaps towards the end, but this is just to show that guideline development group is meeting later this year at WHO to look at the second generation LAM tests, which are better performance actually in people living with HIV/AIDS. And even third generation LAM tests are undergoing clinical evaluation potentially as a point of care for all PTB cases, not just HIV positive. So this would really address the access issues, because this is obviously a test that one can do, at the bedside, wherever the patient is. It's a rapid test. Then multi-disease diagnostic platforms like Gene Expert, Abbott, Roche, TrueNat, etc. These are very good because they can be used for multiple diseases, and they address efficiency part of it. Cost one needs to look at. And then, of course, the next generation sequencing. As I mentioned, the first WHO catalog of mutations was released in July. There are future updates planned. And also there is a guideline development group planned for 2022. And this would really address the feasibility of universal DST. Next slide. TB in children. Next, just a word to say that, we know that there are millions of children infected, 7.5 million infected, 1.2 million children who developed TB in 2019. About half of them, or more than half, are adolescents, and quite a large number of deaths, 230,000 estimated deaths, 80% in children. under 5 years. 96% of deaths are in children who did not get TB treatment. And 36,000 of these are among children living with HIV. Next. So again, pediatric TB, as always, is a gap. And this slide shows that if you can click once more, the percentage of missing TB patients in different age groups is highest in the lowest age group. And next. And the reasons for that are next. We know the reasons why in young TB children, it's difficult to get specimens. It's the lack of sensitive point of care tests, overlapping with other symptoms occurs, and sample collection and X-rays are non-specific and so on. Next slide, please. So in 2014, there was the guidance for national TB programs, essentially based on history and clinical exam, X-ray, tuberculin skin test, etc. But also samples, not just gastric aspirate, but also stool, nasopharyngeal aspiration, and so on. And there is now a new guideline and operational handbook that is likely to be released by WHO by the end of 2021. And here the evidence on accuracy of integrated treatment decision algorithms, which means you combine signs and symptoms, diagnostic tests and imaging into a decision algorithm, as well as the evidence on the use of expert ultra on gastric aspirate and stool samples. So these will be the updates coming later in 21. Next. Next, please. So we know that, a survey that we did looking at essential health services across about 150 countries showed that almost every country in 2020 reported big impact on essential health services, whether it's immunization, maternal and child health, or NCD care, but also TB, malaria, and HIV. What is the impact? So one is impact on health system, and people could not access care. Two reasons for that. One is the lockdown restrictions, which prevented people from traveling to the nearest health center. And second was that the health system itself had completely pivoted to taking care of COVID, and everything else was given lower priority. Now, of course, things improved since then. But when we look at the impact of COVID on poverty, on the loss of jobs and livelihoods, on malnutrition, we know that more people, recently there was a status of food security report that the FAO and WHO produce every year. There were 800 million people in the world today who do not have adequate food to eat. And almost half the world's population does not have a good access to good nutritious diet. And a large part of this is being fueled by conflict in many countries, but also natural disasters, and COVID has taken a toll. So what is likely to happen is that the pandemic will come under control, particularly with the effective and safe vaccines that we have. But TB is likely to continue to kill 4,000 people a day and may even increase, because we know that there's a clear link with malnutrition. Malnutrition is the biggest driver of TB in many countries outside sub-Saharan Africa. In India, certainly, malnutrition is a much bigger driver of TB than any other risk factor. And so if poverty and malnutrition increase, then TB will increase. I also looked at the most recent National Family Health Survey data that's just come out for 17 states and 5 UTs. Almost all indicators of malnutrition in children have been worsened. And mind you, this was pre-pandemic. So despite all our national efforts on trying to improve nutrition through Poshan Abhiyan and so on, the indicators are actually getting worse. We have to keep that in mind because of the link between malnutrition and TB. Next. So we already talked about this. Next slide. This just shows in 4 countries, including in India, what was the impact on TB case notification. But India has done very well to try to recover from that, and the bidirectional screening and other initiatives have helped to bring back. But I would like to hear from the DDG TB, like where are we today in terms of case notification in India, and are there areas or pockets which are doing better or worse? Next. Next slide. So I think we can skip this because we already talked about the challenges of TB, and especially when it comes to COVID, overlapping symptoms and so on. Obviously, then again, you have to use clinical judgment in terms of history of contact, the X-ray findings, and acute onset is what can distinguish. But we know in children, even severe TB can present sometimes acutely. Just a word on BCG. There was initially a lot of excitement on whether BCG can confer any protection. Well, BCG is one of those live attenuated vaccines. There are others like polio also and measles, which stimulates innate immune response. And for example, we know that BCG given to neonates for at least 6 months or so, those babies have a lower risk of sepsis. So that's probably because the innate immune response. So there are clinical trials going on globally, and as of date, we have not seen any data that that shows that BCG is protective or has benefits against COVID. And so we also need to make sure that we should continue the research, but make sure that whatever supplies of BCG are there globally are used for neonates, because we know that it does protect them against severe forms of TB and death. Next. So I want to say a bit about our approach to R&D and then end up with perhaps where do we see the gains in COVID in terms of technologies being useful for TB. Next slide. I think science, research and development have actually been the only bright point or silver lining, I should say, in COVID, in the pandemic. And at the WHO, the science division has been very much at the center of trying to convene globally researchers, academics, public, private sector to develop new tools. And in February 2020, we developed a research roadmap for COVID, which has guided the research in many areas. And we have been updating that every 6 months. We have a global consultation. And one of the early things we did was to put out what are called target product profiles for vaccines, for diagnostics and therapeutics. So target product profiles describe what a developer should be looking for in terms of benchmarks. So for vaccines, we said it has to have a minimum of 50% efficacy and then a safety record of at least 2 months before an emergency use listing can be provided to a vaccine. And all the regulators, including FDA, EMA, all regulators around the world actually accepted that that could be the benchmark. So I think we are all familiar with this graph. If we can just click next, that we need new tools. And next, to some extent, you can have an impact, by scaling up the currently available tools and also by pursuing universal health coverage and social protection. But later on, we need the new tools. And the idea was that by 2025, we should have a new vaccine or a better vaccine, new drugs and treatment regimens that can cure MDR and XDR TB and also drug-sensitive TB, and better treatment regimens for latent TB infection and a point-of-care test. These were the goals. And if you introduce these kind of tools, then you can start seeing the big reductions in TB incidence that are needed if we are to achieve the goals, the SDG goals, the end TB goals, but also the Indian goal of TB elimination by 2025, which is a Prime Minister's call that he made in 2018. And we are slipping back because of COVID, because of other reasons. So we need to take stock to see where are we and how are we going to accelerate progress. Next. So we need research across the spectrum. It's not that we have to wait for somebody to develop a new drug. Of course, we need new drug discovery, new vaccine discovery, new diagnostics discovery, but there are also big gaps, in the cascade of care. We know that less than half of people who are suspected to have TB eventually get tested, get diagnosed, start on treatment, complete treatment, and have a recurrence-free survival. So there are a lot of missing gaps there in the linkages, in retaining people to care. This is what we talk about, patient-centered services, in pharmacovigilance. And then on the regulatory side, we need to really think about how do we move these new regimens, new vaccines, new products through the regulatory system without taking years and years to do that. Because unfortunately in TB, everything takes too long. Look how quickly we moved in COVID, how many vaccines, how many drug trials were done. Whether to prove that it's ineffective or effective. The fact is that when you get together, you have a mission mode, you can actually do things much more efficiently. We have biorepositories now. The Report Consortium in India has established biorepositories from TB patients, their household contacts, latent TB. These can be used now to test some of these new diagnostic technologies that entrepreneurs and biotech companies may be developing. Similarly, we should have clinical trial sites across the country, which are continuously moving into new clinical trials and helping to answer the remaining questions. Next. And investments, of course, need to be made. And India should be making massive investments in TB research. All aware of the India TB Research Consortium that was initiated when I was the DG ICMR, and happy to see that it's still very active and functional. But India accounts for 27% of the global TB cases and about 35% of deaths. So if we don't lead on TB research, who else is going to lead? These are all the different documents that you can find from WHO that talk about the TB research priorities, as well as the product profiles and the target the preferred product characteristics. Next. This is a global strategy on TB research and innovation. This was accepted last year, and this will be reviewed every couple of years by the World Health Assembly. Next, so that we can keep track of how much research. This is a very interesting model that we are promoting at WHO with multiple partners. It has about 30 partners in this model, looking at a gap, like for children, what are the gaps in terms of HIV medicines, TB medicines, and really working end to end by prioritizing what exactly do we need, then evaluating the product. Then, of course, the development is done by companies or by researchers and academics. These are mostly product development we're talking about. Regulatory affairs need to play a role here. And then we mustn't forget the delivery side. Very often you have innovations which then sit on the shelf for a long time because there's no way of either adopting the national guideline or procurement, rollout, uptake, training, monitoring. So again, I was discussing with Dr. Singla the challenges of training, for example, in a large country like India. The use of these kind of platforms obviously can play a very big role, but it needs much more than just the digital platform. It needs people who are trained and who will stay in their positions for some time and commit themselves to TB, particularly at the district level. Next. And pregnant and lactating women always come last. So there are many, many publications now that say that we should start looking at it differently. Instead of saying, oh, it's a vulnerable population, leave them out. We should think about them as a complex population. We should protect them through research, not protect them from research. And instead of presumptive exclusion, we should do fair inclusion. So wherever there is no contraindication, we should include them in research studies. Next. So some of the priorities we already talked about. It would be wonderful to have a biomarker test that you could just do on a finger prick, for example, a rapid test, a triage test. We need to replace sputum microscopy completely, and also rapid DST, so that if you have the result on the same day, you can start the patient on treatment without any delays. Similarly, in therapeutics, we need more effective preventive treatments. Okay, now we've got 1 month treatment regimens, 3 month treatment regimens. We need to make sure that those are being rolled out. And then, of course, we still keep on searching for that short, effective treatment regimen for both drug-sensitive and drug-resistant TB. And it's wonderful now to see some of the recent clinical trials results, like the NIX-TB and the ZNIX trial showing 6-month regimens for XDR TB being highly effective. So these are things that we need to scale up very rapidly here, because we know that the treatment outcomes currently for pre-XDR and XDR are are not high at all. In fact, are very low. Next. On vaccines, well, there's very slow progress. The VPM 1002, that's made by Serum Institute, recombinant BCG, that's undergoing trials. And the TB consortium, again, is promoting the trials in household contacts to see if you can prevent them from getting TB. In fact, it would be wonderful if you could prevent household contacts from getting TB by a single shot of a vaccine, rather than giving them 6 months of isoniazid. So I hope to see results soon. And then there's a BCG revaccination trial going on, which is led by the Gates Medical Research Institute. And then, of course, there was a couple of years ago, the M72 vaccine from GlaxoSmithKline, which showed a 50% reduction in TB incidence when given to people with latent TB. Now, this vaccine has obviously needs to be taken further. WHO has been pushing. The company has handed over this vaccine to the Gates MRI, and they are now planning further clinical trials in different population groups starting in hopefully 2022 or so. But again, it's taking time. So India needs to be again leading at the front in trying to do some of the trials. And you can see that now we have mRNA platforms. So the mRNA has been so effective for COVID. The company BioNTech is very keen now to develop mRNA vaccine. And I know there are Indian companies also working on mRNA TB vaccines, as well as viral vector vaccines. So again, making sure that we can do the clinical trials as rapidly as possible is going to be critical. Next. Now, these are some of the new documents again on what we would expect to see in a new TB intervention of a therapy. Next. And then this was a recently released TB vaccine roadmap. And this is quite useful because it goes all the way from basic science and animal models and clinical trials to epidemiology modeling and ensuring an optimal implementation. So it's not just on the early development, but once you have a vaccine that looks promising, how do you actually scale it up? And again, we've got a lot of experience from COVID now, and India luckily has excellent vaccine manufacturers. And this is an area where we could again be leading. Next. Okay, yeah, so this is the same. It's just that, the last part of this, if you look at the coverage and equity gap, this is equally important. So that's why now we are having consultations where we are addressing not just the discovery side, but what happens if you have a vaccine that's 50% effective? How are the regulators going to think about giving licensing to a vaccine? What is going to be the cost effectiveness of a vaccine for newborns versus a vaccine for adolescents versus a vaccine for adults? How will we administer an adolescent vaccine program? And finally, what will be the cost to the national program to do that? All of this needs to be thought of in advance so that as soon as there is an effective vaccine, we can take it forward. Next slide. So that's why it's important to involve the policymakers also in these discussions. So we are having regulators, policymakers, researchers, all coming together to discuss. Next. Next slide. Yeah, so that's my last part. And there are 3 or 4 key issues here. One is the use of digital tools and artificial intelligence. I mean, we've all seen the kind of apps and chatbots that are now so common being used for education, for risk assessment, for referrals, for contact tracing. We have the eSanjeevani platform that's being used for teleconsultations. So all of this can be repurposed for TB programs so that we can provide even better patient-centered care. Then there are innovations in artificial intelligence, whether it's automated reading of chest X-ray images or whether it is in analyzing cough using artificial intelligence and digital stethoscopes, which can differentiate the different kinds of cough. So if we're able to use some of these with improved battery-operated ultra-portable digital X-ray systems, then you can see how quickly we can actually screen people for TB, and then the AI algorithm reads it, and then it can be read later by a doctor just to confirm. But again, this needs to be implemented, perhaps initially as implementation research mode at a population scale. So it should be implemented in several districts to see whether we're actually able to improve and increase the case notification. Next. So one is around digital tools. Second is around making TB diagnosis simpler and closer to homes. Again, a lot of innovation in sample types, sample collection methods. We now have home testing kits, self-testing kits using saliva, mouthwash, oral swabs, absorbent strips, and face masks. All of these have been used for COVID-19 and are now being tried for TB. An easy to obtain sample where you don't need a sputum sample would be revolutionary if it could be just saliva or a mouthwash. Again, look at the kind of innovations in decentralized testing. We've tried drive-through facilities, mobile testing, community health workers, pharmacies, schools. All of these places have been used as testing facilities. So you could do community-based, mass testing and screening, self-testing kits using PCR, and we talked about the different sampling methods like oral swabs. Next. So the second area where we can really improve is diagnostics. The third is also related to diagnostics, is using these multi-disease molecular technologies. Many countries already had gene expert machines for TB and also viral load testing machines for HIV. These were rapidly reprogrammed for COVID and have been using for both TB and COVID. Now, bidirectional testing, of course, is very good, but in the long term, let's look at, can we take these technologies now to all districts and sub-district level, so that every individual who has suspected TB actually gets a rapid molecular diagnostic. And again, I'm not sure, and perhaps the DDGTB can mention about what is the coverage now for universal molecular testing and universal DST in India. Next. Data. Data is, look at the way we get real-time data in COVID, minute to minute, hour by hour, we know what is happening. There's been real-time data sharing, aggregation, analysis. WHO has huge databases that have been developed. There is the GISAID platform, which has over 2.5 million whole genome sequences. Imagine, in 1 year, we have 2.5 million whole genome sequences. For TB, we have nothing like that. We don't have a global genomic database. So we're trying also to think about other diseases where we need this kind of thing. In TB, we still are analog system, whereas COVID is a digital disease. So we need to again apply this same real-time visualization, real-time data, using also crowdsourced data, connecting diagnostics to the data systems. All of this can help improve TB surveillance and case notification. Again, India is probably doing better than some other countries in this regard. Next. And then, as I already mentioned, the kind of technologies, biomarker point of care tests, multi-disease platforms, next generation sequencing, all of these have got highlighted during the COVID pandemic and could quickly be repurposed for TB. Next. So I think to conclude, obviously the key priority now is to make sure that we are continuing the TB program, both prevention and treatment services, making sure that supply chains are not affected, and using innovative methods to monitor patients. Like I know that last year there were treatments had to be distributed to patients for 1 month, 2 months, 3 months, but we can use the digital technologies, mobile phones, etc., for keeping in touch. We need to strengthen integration of services, extremely important. TB needs to get integrated with our primary healthcare services, especially now that we are focusing so much on the health and wellness centers. And I'm not sure exactly how that is happening in the field. So again, something that I'm interested in. Community engagement is critical. And without that, even those places which were able to do it successfully had much better COVID control than in places where everything was top down without any kind of community engagement or empowerment. So this is critical. And again, for DTOs, I think thinking of ways in which communities feel involved and they are also able to give some feedback to the program so that it becomes a shared responsibility. Otherwise, I don't think TB elimination is really going to be very feasible. In urban slums, probably it is easier. In Dharavi, we saw how the COVID pandemic in the beginning, it looked really very scary, and how it was turned around and how they were able to get on top of it. It was done basically by the outreach to the people who are living there and through their cooperation. So I think if we do not capitalize on the lessons learned from COVID, particularly on promoting innovation and R&D, we would be missing this opportunity now that we have. As I said, we have a lot of catching up to do. When we look back and count the numbers, I think we will find that we have had a setback in TB control, and therefore we will have to work extra hard actually to catch up and to ensure that, as I said, we meet the Prime Minister's goals for India as well as the global goals. I think that's my last slide, and I'm going to stop there and turn it back to the organizers, Rupak and Neeta. Thank you so much.
Thank you, ma'am. Thanks a lot. It was an excellent deliberation, and you have covered almost all the topics concerning TB and COVID, ranging from diagnosis, treatment, drugs, vaccine, artificial intelligence, research, community engagement. So there was so much to learn from this presentation. Thanks a lot for it. And there are some people who would like to ask you questions. So can I take their questions?
Yes, of course. Questions as well as comments, brief comments are welcome.
Yeah. So Dr. Sagar, please unmute yourself, Dr. Sagar. Yes.
Yeah, good afternoon, madam. Very nice presentation to clear many doubts. I am practicing in the area of Mulund, Mumbai as a MD chest physician associated with the government sector as well as my private practice. And we have a MDR-TB OPD in a municipal corporation run hospital. Now, in Mumbai, we see lots of MDR-TB, XDR-TB patients in private OPDs also. But now the problem comes when the patients are not willing to go to the government hospital and start the treatment there. In such patient, we cannot give bedaquiline, delamanid, such new agents, and which compromise the efficacy of the treatment plan from 70% to say 50%. So do we have any plan that even the qualified private practitioner can start with a bedaquiline based treatment to give the maximum benefit to the patients? Rather, if they are not willing to get transferred to the government setup. So will you please guide us on this?
Thank you, Sagar. I think I'm not I'm not the right person to answer this question, because this is obviously a national policy, and probably DDG-TB is listening. But I would say that it definitely, I would encourage that this should be done, particularly in cities like Mumbai, where a lot of care is being provided by private practitioners, and where one can have a system where there could be an oversight, a governance, a reporting mechanism. If a particular doctor, let's say you are treating 3 MDR-TB patients, you're given the course of treatment, it's your responsibility then to report back on the outcomes. If this can be done for DSTB, and we had a very good demonstration in Chennai. We had teamed up when I was still in NIRT with the Chennai Corporation and a number of NGOs. And there was a very successful program of using private clinics. They were in fact designated as centers of excellence, as Nakshatra clinics, we called them. And in those clinics, patients could come, they got free diagnosis, gene expert, they got free treatment because the state Chennai Corporation was giving the drugs, and the doctors there had to take responsibility for follow-up, for compliance, and for reporting on the outcomes. I feel that this kind of a win-win private-public partnerships are the need of the day-to-day. Otherwise, again, I'm afraid we will not be able to control TB, and ultimately it's the patients who suffer. But of course, till such a policy is taken, I think, Sagar, you'll have to really counsel the patients to go to the medical facility in the government where they can get the best treatment. And then you can still keep a contact and follow up the patient if they feel more comfortable.
Thank you, ma'am. Thanks a lot. We have Dr. Vashisht STU Delhi, who was DTO BJRM earlier and is now the STU of Delhi.
Good afternoon. Good afternoon, ma'am. It was very nice presentation and quite informative. So as we have suffered because of COVID, there were challenges the staff as well as, doctors who were engaged in TB care, they were also afflicted with this pandemic. Gradually, the things are improving. And as you rightly said, this is the time when we have to apply ITs and, innovative methods. But still, there is a challenge, and we have to involve private practitioners, as Dr. Sagar has pointed out. So unless we have, teaming up with our PPSAs agencies, so this is not going to be possible. But right now things are gradually rolling back, and we are in the process of training, our staff members right till the district level and subsequently till PHI level. But much needs to be done. And as you said, enough time has been lost, so we have to gear up. Thank you, ma'am.
Thank you, Dr. Vashisht. I totally agree with you. And in addition to going, we should not try and go back to status quo. We should try to do better than what the program was before, using these new things. But we'll have to take a little bit of risk. We have to think a little bit differently, and we have to be willing to embrace, let go of some control. In government, we tend to have a lot of control, and to some extent it's necessary. But we saw in the COVID pandemic that it doesn't work, that unless you develop partnerships, whether it's with the private sector, whether it's with NGOs and civil society and patients themselves, communities, it's that much harder for us to push the program. So thank you for your comments.
Thank you, ma'am. Just for your information, we are joined by more than 15 state TB officers right now from Rajasthan, UP, Orissa, Mizoram, Kerala, Delhi, Nagaland, West Bengal, Himachal Pradesh, Assam, Sikkim, Gujarat, Tamil Nadu, and Mizoram. And in fact, Delhi state is doing its PMDT training, and they have put their just listen to you. So all the DTOs of Delhi are listening to you right now. The session is being broadcasted to their training. So thank you, Dr. Vashisht, for making it possible for us. And we are joined by more than 400 district TB officers. We have faculty from all the medical colleges, and we have very senior faculty like Dr. Rajendra Prasad and Dr. Jayakishan who have joined us. We have Director NIRT Chennai, Dr. Padma with her team. We have Director NTI Bangalore, Dr. Somshekhar and his team has joined us. Dr. Malik Parmar with his team of WHO consultant has also joined us. And as you can see in many pictures that there are STDC directors and their whole team who are listening to us. So it's an overwhelming response to your talk, and I can just take one or two more questions. I'm sorry. So we have Dr. Sangeeta Sharma. Dr. Sangeeta. Kindly make your questions brief as we are short of time. Kindly unmute yourself. Yeah.
Yeah, hi, Dr. Soumya. It was an excellent presentation. I mean, I don't needless to say about that. But I would just like to stress on one thing, you being a pediatrician and you being at the helm of affairs, the trials on diagnostics, at least it's understandable that we are concerned about the safety of newer drugs being tried in the as an initial part in children, because we want data on adults so that you can, in the next phase, we can use that drug as a trial in children. But I feel no reason why children need to be left out for the diagnostics. Whenever there is a newer diagnostic, the children are again taken up in the second lot. So that is my urgent request and concern, that we need to, at least open the trial on diagnostic and include children even in the diagnostic trials. Over. Thank you so much.
I agree with you, Sangeeta. I think we are both pediatricians, so we would have the same view. I think in the past, the challenge was that, you're looking for a gold standard case, and that's much easier to do in an adult with sputum smear positive TB. But today with molecular diagnostics, I think there's no reason why we should not, in parallel, evaluate all new diagnostics in children also. So, and we can take a lead in that, I think, in India. And I see that We have
Dr.
Alpa
Alpa, kindly
and
unmute
others,
yourself.
and Yatin.
Yeah, thank you, Madam. It was an excellent presentation as usual. A pleasure listening to you. I just had one question now. These days we have rapidly updating guidelines and the guidelines change very frequently, but it becomes difficult for people to change their behavior and their, clinical behavior, I would say. So what is your suggestion, madam? What innovation we can do in training so that guidelines which are made so meticulously are practiced in the field condition? And that's a challenge we always face.
Yeah, that's a really good point, Alpa. And as you say, it's a behavior change. That's the biggest challenge. So one of the innovations I think that we could try is having these decision support tools available for doctors, healthcare workers in your mobile or in your laptop or iPad, which you can check. Because what happens is sometimes there is a small change in the recommendation. There could be a change in dosage, there could be a change in one drug, but then we are waiting to print that entire book again. What we did for COVID was come up with something called living guidelines, where you're constantly reviewing the literature, and when there is enough evidence to make a change in the recommendation, you make that change and you update it on a digital platform, so that you add on that particular change. Everything else may remain the same. You may be replacing one thing. So I think this could be tested now, because first of all, I also find it very difficult. I was going through the PMDT guidelines, and hats off to all of you who are managing these patients and with all the complexities involved. If I had a decision support tool on my phone where I could feed in some of the details of the patient, like the DST results, etc., the age, sex, any contraindications, and if I were able to get a regimen that were created for me based on the PMDT guidelines, then I would find it much easier as a practicing doctor, whether in private or public sector. So maybe this is a suggestion for also, I know that Dr. Malik and others are on the call and working closely with you all. Why don't we try out some innovation like that in India? And the other thing, of course, is that if we change guidelines too frequently, then it's very difficult to redo the training. So again, if you have just one specific change which can be highlighted, you don't have to go through again the whole process. That change alone can be provided as an update.
Yeah, Dr. Soumya, again, thanks for an excellent deliberation as always is. About this, I think when you called me again, you raised this issue that the newer update in the guidelines again is also not very simple. It is quite complicated. Yes, it is. And the issue is in our country, we have to run with the science, we have to run with the latest updates, new drugs, the newer diagnostics, the newer regimens. So we try our best to make them as simple as possible, but still. And also the issue is about the trainings. The moment we start from Kashmir to Kanyakumari, it takes about 1.5 to 2 years to train the entire lot of DTOs of the districts. And by the time the new evidence comes, the guidelines they have changed. So what at our institute we are trying, I'm hopeful it will be successful, is that we are trying to develop an app for difficult to treat TB cases, or even for simple cases, that the DTO or the people in the field, they will feed the data of the patient, including the history, the what all drugs patient has taken or not taken, the DST pattern, and we will feed in the guidelines, including the updates as and when they come. And it helps the clinician to know what will be the ideal regimen for that patient. So once it is developed, it will be validated in our own institute, and then through this, with the help of CTD, and the National Task Force, we will try to validate this across the country and see. So let us hope, we are working on it, but yes, the new, rapid changes in the guidelines, they remain a challenge.
Thank you. Yes, I'm very glad to hear that. In the past, TB, we knew nothing will change for 10 years. So we could take our own time in training and rolling out. Now, luckily, we are having more positive news coming even for TB. There are more trials happening, and so I think moving to this type of a digital platform where you can update it more rapidly will be much more useful, because, if you take 2 years to train, generally WHO would have come up with the next guideline by then. So then you have to start all over again. But yeah, best of luck for that initiative.
Thank you. We have a question from Dr. Rajendra Prasad, sir. And this will be last. I'm sorry, we have many hand raised, but we will not be able to take them due to shortage of time. You can send us the email or you can put them in your chat and we'll try to take up those issues.
Thank you, Neeta, for allowing me to just a few of my comments. First, thank you, Dr. Soumya, for a very interesting and very, informative lecture, which one can know that what is happening in TB and especially TB and COVID. 2 points, as I totally agree that guidelines have changed very frequently in last 2-3 years. So it's a propagation. It's means to the not only to the government sector, even to the private sector is very essentially needed, and new innovations has to be thought like we did in COVID, all on the digital platforms. So such type of innovation will at least maximum number of people, doctors in government as well as in the private, they know about these changes. One. Second issue as raised by some Bombay person, that he was very right that as you know, you see the estimated MDR numbers in India is around 1,25,000, roughly this figure. And with our best capability, although it has improved a lot, we could treat only about 60,000, around 60,000 cases before the COVID, if you see. So large number of patients are outside the program. Dr. Mandal is also here. So this is for everyone to think that some limited access to the private sector to all these newer drugs, so that every patient can get. But although I know that every private sector people should convince their patient go to the government, but it's still such type of scenario is there. You can see from figure that only literally half of the patients of MDR TB they are ultimately coming to the government. So some limited access, something I was attending last JMM and I raised these points in last JMM also, that there are some thinking must be there in the government that how it can be made at least limited access to some of the experts in the field who can manage these drugs and can cooperate with the government. And there these drugs can be made. So once again, thank you, Soumya, and it was very nice to see you once again. Thank you, Soumya.
Thank you, Dr. Rajendra Prasad. Always wise words.
Dr. Neeta, can I make a comment?
Sure, sir.
Yes, one of the very important, very interesting points Dr. Swaminathan made, which I noticed, that vulnerable groups like pregnant women or children have to be saved through research rather than from research. Now, because being a director, I have recently seen sometimes the roadblocks whenever a research proposal is being considered are too many. And all of us have the responsibility of probably relaxing them at a stage where we feel that the end point of the research could be beneficial for these groups also. So maybe it is as a forum, I would like to reiterate this one point attracted me very much. And that thing we can do. Because there's a large segment which is vulnerable and which needlessly does not get the cover of the research as well as the initial use of those drugs and changes which are taking place. And otherwise, overall, whatever have been other comments of others, it was very informative, wide-ranging, as well as it covered many of the aspects. All of us have been familiar with the complexities of the issues raised by TB and COVID, as well as the opportunities the situation has raised, because COVID has taught us to be more proactive, faster, and to be able to implement things in a faster mode. We have to use the same mode in our TB control strategies. Thank you. Over.
Could I request Dr. Swaminathan Pandey? I think she had her hand up. I'd like to hear from her if she's still there. Dr. Swayam, are you there? Maybe she left.
Can I have one question, madam?
I think I see her.
This is Dr. Patil from Jalma. Nice to
Let
hear.
me hear from Dr. Swayam first. I want to hear from people who are in the field. Dr. Patil, I saw you'd made a comment on serodiagnostics.
Yes, ma'am. Yes.
And I think unless we come up with a test, what when I said biomarker, I meant a blood biomarker. There are some very promising biomarkers now which are based on genetic changes which occur in response to MTB infection that could help to predict the development of TB. So for example, if you tested household contacts, you may be able to pick up those who have a higher risk of progressing to TB in the next 12 months, and you can target the preventive therapy just to those individuals. So we know those kind of biomarkers. We know that the antibody tests for TB do not have sufficient sensitivity. So I think if there's something very in the research, we can move into broader testing in the field. Dr. Dholakia, you wanted to make a comment? Dholakia, muted.
Unmute yourself.
Yeah, so thank you. Each I want to
palliation as well. We know a lot of colleagues need that rehabilitation, and now we are seeing long COVID. Those people are also going to need. So I agree with you on that. And on the other point, sorry, what was your first?
Airborne infection control, use of UVGI.
Yes, UVGI. I think we need to really use it in those settings, mostly like inpatient settings and those highly contaminated. It has to be, of course, well monitored and properly used. But also the use of masks and respiratory hygiene and hand hygiene in general now is so much more acceptable to the public. Earlier, even masks was associated with stigma because it as though only those people who have disease are being asked to wear masks. But perhaps now, universal wearing of masks in health facilities will continue. And it's also at home, TB patients could be encouraged to wear masks at least till they are infectious. That may actually have an impact on incidence. And in fact, somebody commented in the chat saying that the reduction in TB notification last year, was it due to a real reduction in TB incidence? Because of mask wearing, we have seen influenza practically disappear. We've had hardly any influenza last year and this year because of the universal respiratory hygiene that we are all following. So for TB, I suppose it would take a little bit longer. I would be very surprised if 2020 drop in notification was because of actual reduction in TB. But in the longer term, it's possible that these kind of precautionary measures we are taking, behavior change, could have an impact. After all, TB is an airborne disease and spread through aerosols. So definitely wearing of masks, maintaining distance, hand hygiene, these are going to affect. So in a way that might actually help us towards driving the TB incidence down. Needs to be recorded.
Thank you.
Thank you, ma'am. We are joined by Dr. Sanjeev Arora, who is the global founder of ECHO. His digital initiative has really helped many people. It has helped in capacity building at the periphery and has helped many patients to get the treatment in the periphery. Now I request Dr. Sanjeev Arora to give his remarks.
Thank you, Dr. for this invitation. Dr. Mandal, Dr. Divan, Dr. Rupak, Dr. Rohit Sareen, Dr. Patna, and others. Thank you for collaboration with us. We are so delighted to have this opportunity. ECHO is a platform, a global platform right now with a mission to democratize expert knowledge in the field of healthcare and education to improve care and implementation of best practices in underserved populations. We currently, so far, have trained 2.5 million healthcare personnel in 179 countries. And we are really delighted that they use the ECHO model. I'm Dr. Swaminathan, who first introduced us. We had gone to her office, Dr. Soumya and Rai, who are also on call, asking her, how can we bring ECHO to the healthcare system? And she the first call she was to NITRD, and so thank you for that. We and our team, I want to thank our team in ECHO India. We have a team of 150 people there. Our mission is to improve healthcare for underserved people in India. And if you're finding the ECHO project helpful, I want to request you all to act as ECHO ambassadors and convince the Indian government and the state governments to use ECHO for all types of health problems, and also in the field of education. We have a very rapid, currently we have about 1,300 ECHO networks in healthcare, but our fastest growing ECHO networks now are in the field of education, where we mentor school teachers to be better teachers in math and science and literacy. And I encourage you all to speak to your colleagues in the government and reach out to us to expand ECHO in India. We have the technology platform that is robust enough to support many more programs. And thanks again to all of you for this great opportunity to be of service. Bruce Strumminger, my colleague in the US, is also on, who is a world leader in TB and is implementing many of these principles in Africa and other parts of the continent, in Vietnam, etc. Thank you.
Yeah. Thank you, Dr. Sanjeev. And Dr. Bruce had mentored our clinic. He helped us to start the concept of TB ECHO. So thanks for all the support. Now I request our DDG TB, Dr. Sudarshan Mandal, to give his closing remarks.
Thank you, Dr. Singla, and a very good afternoon to everybody who have joined this program physically or virtually. And a warm welcome from Central TB Division, Ministry of Health and Family Welfare, to all the clinicians, the faculty, that STOs, DTOs, and the organizers, Dr. Rupak Singla, Nita Singla, and a director NITRD, and NTF chairman, Dr. Hordaz, and all other fellows who have joined in this. I mean, I can see that 480 people have joined already, and it's a huge attendance as far as I mean this virtual program is concerned. And I'm blessed and honored to have Soumya, I mean, to be present here as a guest speaker, and she has deliberated nicely, and I mean, she articulated all the facts of TB in the scenario of COVID, what is happening globally. Also, she has given special space to the Indian scenario also, and taken up so many questions from the DTOs and other fellows. And so it was an excellent speech. And thank you very much, ma'am, for giving that lecture. And your presentation is one of the best I have ever seen. So having said that, I mean, at the outset, I would like to congratulate the NITRD team, starting from that director and other HOD of other fellows for conducting this type of difficult to treat clinic at their center, National Difficult to Treat Clinic, since last 1 year. And I know that they have included, I mean, altogether, I think 17 national experts in their team, and which includes also 6 pediatricians. And the figure what I got that they have treated already more than 40 cases at their center, this type of difficult to treat cases, which include probably non-responsive DRTB cases and pre-XDR and XDR cases. And I personally referred a few cases to them, and that was nicely tackled up by Dr. Rupak Singla and his team. And, I think I should mention something what we are doing regarding this difficult to treat. So I wrote to all STOs of the states and union territories to set up this type of clinic in their states just 1.5 months back. And I am glad to see that already 15 states have started their difficult to treat clinic at the state. and they are tackling those cases also. And I must mention the name of the states. It's West Bengal, Karnataka, Andaman and Nicobar, Tamil Nadu, Gujarat, Maharashtra, Bihar, Delhi, Telangana, Odisha, Uttar Pradesh, Himachal Pradesh, Kerala, Manipur, and Rajasthan. So congratulations to them, the STOs, and of course the STF also, STF team also for starting their difficult to treat clinic in their states. So in this in the vein, I would request to all the other remaining states and union territories to start this type of clinic in their state also. Altogether, we have 36 states and UTs. So remaining state should start this type of clinic, because you know that we have to reach closer to the people who are suffering from DRP and also having problem regarding the side effects of drug and also any other challenges they are facing, if possible at their state level also. So thank you very much, all the STOs and all the coming STOs who will establish this type of clinic. And I would like to congratulate Dr. Soumya for this nice and on this important topic of TB in the COVID scenario, in the COVID time. And we have learned a lot from you. So in future, I think you will be joining with us in another virtual program, if it's not possible to be present in a physical setup. And central TB divisions, regarding the scenario of TB program in COVID, I can say that from the central TB division, we repeatedly issued guidelines to the states and union territories how to cope up with the COVID scenario in the country since March 2020. And you know that advisory have gone from the secretaries, additional secretary, even from me and the previous DDG also. And we held so many meetings virtually with the STOs and other people. I mean the consultant, WHO consultant, even the regional team leads, how to cope up with this situation. And I can give some figures that that is not so much discouraging. I think that we have started this activity for TB elimination in the country after the commitment of Honorable Prime Minister of the country on 13 March 2018, and we have put all the machineries, the central TB division, the state TB cells, the district TB cell, even the tuberculosis unit on the mission mode, and we trying to do that, and we got the results also. You know that the missing cases, which was in 2017, is round about 1 million, 10 lakhs cases. That has been reduced in 2019 to merely 2.4 lakhs. And from my perspective, I can say that we don't want to keep any TB patients untreated and left undetected, because you know that if we keep some patients undetected and untreated, they will continue to transmit the infections in the community, in the close contacts. And also there is a risk of death. Within a period of 3 years, 50% of the untreated and untreated case will die. So this is we cannot allow it. This is unacceptable to for our program. And but after that COVID came, the notification has been reduced to a little. There was 25% reduction of TB notification in 2020 itself. But we have revived our program very much in the year of 2021, and I can say that data of collected from the NICSA 2 days back, that already 11.5 cases have been notified in our ICT system, and it's not small. So we are hoping for the 50 lakhs in the year 2021. And regarding the activities we have undertaken through the advisories from the central level to the state level and even to the district level. So we started, that bidirectional screening of TB and COVID, and also screening of the ILI cases and SARI cases, so that they have been searched out for identification of the TB cases among them, and that is going on still now. And that yielded a number of good number of TB cases in our program, and that were notified in the system. And we have also started, that for demand generation of the country, we have started initially in November 2020 from the initiative of our Union Health Minister, that TB, Jan Andolan for TB, and later on 24th March 2021, on the auspicious day of World TB Day, our Honorable Union Health Minister has launched TB Mukt Bharat, progressing towards TB elimination by 2025. That is 5 years ahead of that, SDG goals. So we are taking all those steps for demand generation. On one hand, we have to generate demands among the common citizens and particularly in the slums and rural setup. And on the other hand, we have to keep the supply line also. That without proper supply line, we cannot satisfy our common citizens who are suffering from TB. And as far as death is concerned, still I think every year we are losing 4.4 lakhs citizens, fellow citizens in this country every year, and that equals to 1,200 cases per day. That's a huge amount. Even I have seen the data of COVID in the country. I think it has reached to the figure of 4.3 lakhs during the period of 18 months. So more people are dying of TB than COVID also. So we have to keep that in mind also. All the TB people are working towards that. And we have arranged also during that COVID time e-consultation, that teleconsultation through our e-Sanjivani platform. Also through our development partner, Clinton Foundation, we have started IVRS, and there is a national helpline for TB and state helpline for TB. So we have activated all the national helpline and state helpline so that people can reach the healthcare provider, and healthcare provider can advise also and give proper consultation to the TB patients. And we have arranged also a doorstep delivery of medicines, and from the facility we have advised you give, instead of giving 1 month's medicine, you try to give 2 to 3 months medicine during that lockdown period and other, restrictive period of COVID, and that yielded very much. And I can say once the patient is diagnosed and notified in the system, we did not, leave any stone unturned, and the figure is high, but we have tried to reach to the figure of 100% as far as treatment is concerned and adherence is concerned. But we could manage to give 95% of TB patients proper treatment and adherence during the COVID period also. And that's a very encouraging result as far as, the states and UTs are concerned. And regarding the, one query raised by one DTO, that what we are doing regarding that patients who are diagnosed in the private setup, in the private healthcare facility. That TB is now a notifiable disease. It's mandatory for the private healthcare to notify the disease in our system. And once it is notified in our system, it's our responsibility of the NTP to give proper treatment to the patients, whoever is notified in the system, and to give the proper adherence to the patients, but either through our most peripheral health worker like ASA and other TB health care, TB health visitors, or through our, that technical adherence technology, 99 dots and more. So we are trying to give the best, support and supply line for patients, and we are committed to do that in future also. That's why, in this year, 2021, got such a huge notification in our system. So having said that, I think we have to progress towards that TB elimination. Not alone by the NTP, but in coordination with all the development partners. That's why we have arranging every month, that TB Bharat and campaign program under the Honorable Union Health Minister. And recently we did that on 5th August. So we are moving very fast. And regarding the scenario as far as basic epidemiology is concerned, regarding that number one, the primary prevention, secondary prevention, and tertiary prevention. People talked about that what rehabilitative service we are giving. We talked about what new technology we have incorporated in our system for diagnosis of TB patients. I can say that, I am very glad to announce that we have already placed more than 3,100 TrueNet or CBNet machines in the sub-district area, and we have to scale up that testing facility to the block area also, because my only goal and our only goal is to reach closer to the people, how to give them that U-Testis facility, even direct testing through net testing. And we have started, that 4 regimens for DRTB also, that all oral longer regimen and that injectable regimen, of course, that is continuing still, and that mono-H regimen, and also recently we have started a beta-glucan containing shorter regimen in 7 states, which will reduce the duration to 9 to 11 months. Not only that, that will have less side effects for our patients. So we are very concerned about the duration of patients and the number of pills they are taking, and also how to reduce the side effects. That's why we are arranging this type of national, difficult to treat clinic at the central level at NIRT, NITRD, and also in various states, so that we could mitigate the sufferings of our patients, particularly the dead TB patients. So that thing, we have another plan also. If we consider the primary prevention, we have, that we have started TP preventive therapy for the household contacts now. Beyond that, under 5 children or under 6 children, and also people living with HIV, we will give TB preventive therapy to the adolescent and adult contacts of the active TB case, the index case. And we have advised that if you know that the IGRA test is not available, you can go directly for giving them the TPT, because what study have shown us that 70% of the adult contacts of a index case are having that bacteria in their body, suffering from that latent TB. So that things we are doing, and we are going to scale up throughout the country. And for that, we have started that's training for of the healthcare provider at different level. That is cascade training. We have trained the S2s first, then state will train the DTOs and other people. The MOTC and other people who are working in the peripheral level, the CHO of the Health and Wellness Center. So if all the states, they have started that type of cascade training for TB preventive therapy. They have started for programmatic management for DRTB also. So that is going on, and that is going on in a very quick fashion. Because we have to. Somebody has told that the period with which we are training our healthcare provider, the another regimen may come. And also you know that we will start the BPAL regimen also, that is maximally 8 months, and that will reduce the side effect of the drugs also. So the type of happening is going on. We are not sitting idle here. We are working proactively, and from Central TB Division, I can say all the people, I mean the people posted at Central TB Division, at State TB Cell, District TB Cell, even the Q units and PSC, they are working very fast. They are working proactively to fulfill the dream of our Honorable Prime Minister to, I mean, eliminate this disease by 2025. And another hopeful news I can give you, that 2 vaccines, you know, that BPM on 002 and Immuvac vaccines, they are on the 3rd stage trial, and also already ICMR has recruited 1,000 close contacts for that trial. And even if we can get that vaccine within a period of 1 year, with minimum 50% or 60% or 70% vaccine efficacy, that will serve our purpose to protect our people from this dreadful disease. So everything is happening, and we are arranging meeting also with the Ministry of Science and Technology, the Department of Biotechnology, the ICMR continuously. I mean, we are in constant touch with them, how to, I mean, get one vaccine, how to get the new technology for diagnosis, how to get a new regimen for DSTB and DRTB. So thank you very much. Thank you for your presence. I mean, this type of support we should get from the WHO headquarters, and I can say that we are getting support from the CRO team also, and the 3 NPOs who are posted here in the country office of WHO. They are giving continuous support to us. They are advising us continuously. And I mean, I am very much optimistic and hopeful to do something by 2025. Thank you very much.
Thank you, sir. Thank you for your enriching information. Thanks a lot. Now I request Dr. Ashok Bharadwaj, Chairperson for the National Task Force, to give vote of thanks.
So thank you, Neeta. So I take this opportunity to thank Madam Soumya Swaminathan for her elaborative, informative, and scientific presentation. So, Madam, it has been always a pleasure to listen to you, even when you were Secretary DHR, come DG ICMR. So you brought all aspects of TB COVID co-infection and enriched us by your enormous knowledge and the work you did for this purpose. So thank you, Madam, very much, and for sparing time for this important session, because your time is very, very busy, very, very important for other activities also. So I thank Dr. Mandal for giving a new vision, a new lead to National TB Illumination Program in the country. And under his leadership, we are achieving many things, many innovations have come up. So I thank all other dignitaries, Dr. Rajinder Prasad, Dr. Rohit Sareen, and in the end, I must thank the Dr. Diwan and his dedicated team who are conducting this activity for the last 4 years and doing this every fortnightly. So thank you, Dr. Rupak. Thank you, Dr. Neeta. So in the end, I want to say 3 things. One is, now the coming period is very crucial. So we must focus our activities. We have to ensure effective infection control and prevention measures to our workers who are working with patients. And we have to stand against stigma and discrimination about both these diseases, which we have to scale up simultaneously dual test of COVID and tuberculosis. And we have to build and strengthen community, youth, civil society engagement in close gaps of care. So I have one last question, student. Last question, madam, for Soumya. TV is there from time immemorial. So COVID came last year. Why we were slow? Why World Health Organization was not so active for developing vaccine against tuberculosis as against COVID, where we have multiple vaccines within 1 year? So that is the last question for madam. So if you are able to answer it, then thank you very much. And again, I thanks everybody who joined this. At one time, there were six participants. Thank you all the participants for attending this important session, and hope that you will be attending these session, and we will be having innovative session in future also, because this is the main objective of conducting these DT3 clinics. So I must tell Dr. Mandal also that within the last 3 years, I have been able to establish these state clinics in 3 states. Uttarakhand is doing today, Punjab did yesterday, and Kashmir did a week ago. So thank you very much.
Thank you, Dr. Bharadwaj. Thanks a lot. And I thank everybody who has joined our clinic today. You will be getting your participation certificate. You must have got for your earlier clinics also. So if you are facing any issues, you can always write to us. And from your registration of the today's clinic, we can see that 1,200 people had joined in today at different point of time, and more than 800 stayed for the more than 1 hour of this session. And with this, I would like to thank everybody who joined in. Thank you, Dr. Soumya, especially for taking out time for us and making this clinic so special for us. Thank you. Dr. Soumya wanted to make a comment. Dr. Soumya, you were trying to unmute yourself. Okay. Thank you. Thank you, everybody.